So before we go any further, the best thing is for us just to have a quick introduction from our two panel members here now. So, Chris, would you like just to say a few words of background,
Sure.
where you've come from and what you're doing these days?
I've made some notes because I
Thank you.
can't remember who I am, so
Yeah.
please bear with me. I'm a retired GP, so I can't claim to represent primary care, but I do know how it works. I was born and brought up in Pershore, married to another GP who's also retired, and we have two grown-up children. After graduation, my first job was in urology. I remember being scared stiff, to be honest. But we saw very little of prostate cancer in that job. It was mostly plumbing problems and emergencies and so forth. Further training in Devon and Norwich, and then I became a partner at Pershore Medical Practice, and my room was literally about 30 yards across the path there. During my time, I was also had a specialist interest in ear, nose and throat in hospitals and in the community setting. I volunteered as the doctor at Shelsley Walsh Hill Climb for many years, and also as a medic on some Himalayan treks. In general practice, patients could self-select, and being a chap, I saw an awful lot of men, so that's where I began to learn more about prostate cancer and the effects that it has. But I also saw the worried well, and I saw the anxious, and balancing all of those things up is quite an art. We'll come on to it later, I'm sure, but the debate about PSA, should we say I was very easily persuaded. I didn't need an awful lot of persuasion on doing that, but I would make sure that certainly we knew what test we were doing and why we were doing it. From a personal perspective, my father has low-grade prostate cancer and has had it for some years now. I get my MPSA checked annually because of that, family history. And interestingly, had a recent spike within the normal range, but spiked nonetheless, and 3 months later it returned back to normal. I'm open-minded about what I would do as far as the diagnosis was concerned if I would get that, and I'll basically, because things are changing so quickly, I'll cross that bridge when I come to it. I retired at the end of 2019. Since then, I've been running with my wife Pershore Wellbeing Hub in the High Street, which is a drop-in centre dealing with all sorts of problems that people in the community have. I teach GPs about business skills and about partnership, and I mentor GPs with all sorts of issues. And I'm still involved at Shelsley Walsh. There we go.
Brilliant, brilliant. Thank you very much indeed, Chris. As ever, a full life, and as my granddad said, always ask a busy man if you want something done. So thank you for coming. Can you hear me still all right, Daniel? Very good. So can we move on to Simeon on my right as well? I'm lucky enough to have met Simeon at a couple of meetings, though you certainly won't remember me. Cancer Alliance things and urology things in Birmingham, but I'll let him tell his story. So over to you, Simeon. Thank you very much.
Thank you. Hi, my name's Simeon Green, and as mentioned, I'm from Wolverhampton. In my day job, I work with children, young people and their families, those that are involved with serious violence, so young people that carry guns and knives and aren't afraid to use them. So that's my day job, but that's not what I'm here to talk about. I'm one of 4 brothers. When I was diagnosed with prostate cancer, I discovered through talking, because nobody ever talks about cancer, certainly not in my family, that all 4 of us have now had prostate cancer. My eldest brother sadly died last year, a year and 4 days ago now, from prostate cancer. And when talking to the family, discovered that my mother, who's large family, she's the eldest of 11 children, and all those 11 families have had prostate cancer in them. So it seems kind of endemic within certainly my family. Black men are more than twice as likely to get prostate cancer, tend to get it at a younger age, and get a more aggressive strain of prostate cancer. So when I was diagnosed, my partner had been diagnosed and was being treated for breast cancer, and was in one part of the hospital having a second bout of chemotherapy, when I was in another part of the hospital having a follow-up, what I thought was a follow-up from TURP, the surgery to reduce the prostate. Many of you will know what that's about. Thinking I was there for a follow-up, to be told that the tissue that had been removed had been sent to the lab, and they discovered cancer cells. So totally out of the blue, and I was handed 3 letters. One was an invitation to go for an MRI scan. The second was to go for a bone scan, and the third was to come back to the clinic 3 weeks later. So I was told I got a very aggressive cancer, because I knew that, but not what the prognosis was. So for the next 3 weeks, I was certain I was going to die. And all my waking hours was thinking about that. And you men will know, when you have prostate cancer, getting up in the middle of the night so many times, each time you wake, it's the first thing on your mind, keeps you awake and stops you getting back to sleep, and so on. So 3 weeks of that. But fortunately, it was well confined within the prostate. I had surgery to have it removed. But there are many things during my experience of all of that, and my partner's experience of breast cancer, that we were unhappy with. And I decided, one of my heroes is a black American woman called Angela Davis, who said, "I no longer tolerate the things I cannot change. I change the things I cannot tolerate." So I decided I'll do something about it. And I started getting involved with the NHS, which has led me to be involved in a whole range of things. So at the moment, I'm a patient rep on a national group for NHS England Cancer Programme. I'm also a patient rep on the board of West Midlands Cancer Alliance. So that's a bit of the NHS that oversees the delivery of cancer services across the old West Midlands County, Worcestershire, Warwickshire, Shropshire and Staffordshire as well, all the hospitals within that. And as being on the national group, I'm currently involved with the implementation for something called GRAIL, which I don't know if any of you are. It's known as GRAIL or Gallery. It's a trial at the moment that uses a blood test to identify 51 different cancers before there are any symptoms. So a game changer if this all works out the way we expect it to. So at the moment, the NHS are recruiting 140,000 people to be part of this trial. So 70 will be referred in, 70,000, will be people with cancer, and the other 70 will be people who don't have cancer or haven't had cancer for more than 3 years. And the age range is 50 to 70 years old. So anybody that's interested in that, men, women, between the ages of 50 and 70, you can find that out through the NHS website. I'll leave it at that for now. That's me.
Brilliant. Thank you very much, Simeon. Perhaps I should refer to the fact that your parents came over in the time of the Windrush scandal. So, not surprisingly, his background is somewhat, sorry to use the word, coloured by the sort of things that went on and didn't go on. Okay. Well, I think all of us would accept that over the last couple of years, the world has changed somewhat enormously, really. But if you stand back a little bit, and Chris was talking to me earlier about the fact that really it's necessary, particularly for men, to stand back and look at the broader picture as well from time to time. And I started I think it's these days called a journey, isn't it? But I started mine back in just after 2000. A GP unfortunately failed to diagnose the fact that I got something going wrong. And so it was a little while later, and just a little too late to be diagnosed with it. So my wife was always slightly amused by the fact that we were we were actually in front of the specialist quite amused by the fact that we were actually delighted to hear that I hadn't got bone cancer when, of course, the bone scans were done, thinking it had already gone from around the sheath of the prostate to slightly further because of the pains that I had at the time. Fortunately, I'm still here, going through the mill, going to lots and lots of sessions. As some of you know, we go quite regularly for checkups and things, and my word though, the change in both the methods of treatment as well as some of the diagnostic systems and the drugs that are used and the oncology that's used now, etc., is quite tremendous, quite tremendous. So the questions that we've had, not surprisingly, cover quite a range of circumstances. And because of that, you'll forgive me for grouping together the questions that we've had into 4 categories. And they are, first of all, just general awareness about the world of prostate cancer. A second theme of PSA testing, because a lot of men still are concerned about it and how it's done and whether there should be screening and the like. We've also looked at how people actually get information. I suppose you could call it, what did I put on the title? Taking responsibility for providing information. Who should be providing the information? And finally, the development really that we're seeing much of today, going forward, lots and lots of things happening, quite interesting, both in surgery and in medical systems and drugs. Good. Good evening. Good evening. Welcome, honestly. Thank you very much for coming at the end of what is a busy day. I'm pleased to say that I didn't keep you busy today anyway, because your excellent CNS nurse, Ronnie, who some of you will know, was charming and helpful to me today. So, welcome. We've just got through intros. Whether it's fair to ask you, I'm not sure, but I will. Those who don't know, Dr. Lisa Capaldi is one of the consultants at Worcester, where we have a fabulous oncology unit. Would you like to say just 1 or 2 words at this stage? Or not?
About myself?
About yourself, to start with. Or is that a...
Yeah, okay, so I started probably in 2013, I think. So I started in Cheltenham originally. And then when the oncology unit set up in Worcester, which was sort of about 1-2 years later, I moved my employment from Cheltenham to Worcester, so I'm now at Worcester as part of the team there. I treat prostate cancer, I also treat bladder cancer, kidney cancer, I do radiotherapy for skin cancers, and I also do a bit of melanoma chemotherapy as well, so it's not just prostate that I treat, so there's a few other things I do. I also have some management roles as well, which take up a bit of time, as they do.
Lovely, okay, thanks very much, Lisa. So we'll move straight into the first of our topics that I described, being awareness raising. We talked earlier about the fact that a brand new, very useful booklet has just come out. It's called Knowledge Empowers. That's quite a useful title, isn't it, really? Knowledge, not info, but knowledge empowers. And I think the booklet is both very well written and really very understandable to all of us lay people. There are more pieces of information these days. I've made mention of little C cards, and you can pick those up. And of course, there's stuff on the web and so on. So a lot of people ask questions about where on earth the best place was to go for it, but importantly, how should we raise awareness about prostate cancer? The Kidderminster and Worcestershire Prostate Cancer Support Group has as one of its key objectives that we raise awareness. Anyway, we have a panel to start answering some of these questions. So without further ado, Chris, can I pass to you and start the answers, please? That would be great. Thank you.
I think probably the most important sort of development in proactive awareness raising has been the...
Sorry, we can't hear you very clearly at the back.
I'll do my best. Okay.
You've got a microphone.
I think one of the most significant things I've seen recently is the the rise in
Do you want to try that?
awareness of HRT so much that it's almost broken the NHS, and that all came from one programme by a celebrity talking about the menopause. So we need Claudia Winkleman or an equivalent to do a TV programme. There you go.
Yeah, I remember when Stephen Fry spoke out about prostate cancer, and as a result of that, the number of men going forward for PSA tests kind of went through the roof. Unfortunately, those messages don't quite get through to black men in the same way. I know that the NHS and Prostate Cancer UK at the moment are doing a lot of work around behavioural science and how you use adverts that put people where the people can view themselves as the characters within the advert. So it then becomes about me and what's happening to me rather than what's happening to someone else. So that's quite an interesting development at the moment. But from the point of view of black men, I've been involved with some work with the NHS and with Prostate Cancer UK. And as a result of that, we now have a national online support group for black men. There are no clinicians, it's just men talking to men about life and living with cancer and so on. But through that, people being better informed and talking with other people is the way to spread that message. I mentioned at the beginning that, you know, I'm one of 4 brothers with prostate cancer in a family. The prostate cancer runs through, but nobody talked about it. So I was the first one when I was diagnosed to actually start to read up, start to find information and start to talk to others. And I think that's one of the ways forward too.
Yeah, I agree. I think it's got to come from sort of national movements, whichever way that is, whether it's through celebrities or through the charities. I can't see any other way of doing it. I know there is a question, I think, somewhere down the line about the prostate or the PSA. There used to be one in Kidderminster, didn't there, in the town hall? So PSA monitoring services. Whether we need to try and reinvigorate those or not, I don't know. I don't know how Chris feels about that, because basically it ends up going to the GP first.
Yep.
And I could be very cynical and say I don't really need any more customers, but I'm busy enough as it is. But
Can we follow that up in just one moment, Lisa, as well? Can you pass that back to me? Is there an issue to do with the proximity of the mics to them? So if you could move the mics right up to you and sit closer to them, let's see whether
so
that
we don't have to
works.
talk to that one.
I mean, the first question was really born of a very good question from Ian Dukes, who can't be with us today, who I said chaired the Rory appeal. And his words were, does the panel feel that prostate cancer awareness has reduced in our county due to the COVID emergency, the halting of the Rory appeal and PSA testing by a local charity, which previously helped to publicise the disease and to get men to discuss it freely. A lot of parts of that, aren't there, really? And I think, you know, our panel has covered quite a few of those points, but I suppose you touched, all 3 of you, on, I thought there's really a follow-up to do with, are the traditional means of awareness raising, and by that I mean meetings like this, or websites, or posters, or articles, or special talks. I mean, Mary and I did talk to a big engineering company recently. Those are, I won't say old-fashioned, but the question is, are they still relevant? In a few words, what do you think? Do you think they're still relevant, please?
Yeah, I think they are.
Good.
It's easy. It's the easiest way to get the message to the people that are actually needing it. Golf clubs, pubs,
Anywhere where
wherever you
men
meet.
go.
Yeah,
Yeah.
it's got to be there.
And you'd agree?
Could I ask something? Is it possible to have
Can we? That's a lovely question. Can I? Thank you very much. Can I come to that in 1 second about PSA testing? Okay, and we'll try and deal with that as well. Are you going to add something more,
I was
Chris?
going to say, I think one of the problems we've seen over the last 2 years or so, that everyone has been preoccupied with COVID. It's preoccupied everyone's thoughts. And now, as we recover from the pandemic, everyone's worried about the price of petrol and the price of heating the home. There is only so much worry that a human brain can cope with. And it starts to ignore things. And for the last 2 years, the older male and female, we've been worried about COVID, and discussion of that is often focused on comorbidities such as heart disease, diabetes, obesity. So prostate cancer has just slipped down the list. And I think the worry about it is still there, but our job is to push that up. But there is where do we're a selected group, and we might want to put it higher than it should be, but actually society might say, actually, no, heart disease still kills more people, so we should have that high. But I think Lisa's right. I think all of those things that you mentioned should play a part. But I think we need to bring all of those back in and start running those meetings again, start having
We
those
need a plan and a campaign, don't we? I think, thanks very much. I think they all contribute to the fact that more needs to be done, and we all need to play our part. I did pick up on Simeon's point that social grouping and social communication can actually probably play an important part. Do you feel there's any need to take that further and become more innovative, Simeon?
Yeah, absolutely. I mean, I know, for example, that in Birmingham, there was a mechanic who offers free MOTs or discounted MOTs for any men who come in who promise to go and get a PSA test. And that started a conversation and got many more men getting tested. I think there's also a role for young people, informing young people, that pest to power. Dad keeps seeing you going backwards and forwards to the toilet. You need to do something about it. And I think the new round of adverts that are coming from Prostate Cancer UK are also heading in that direction too. And I think there's a role in social media and young people in social media. Again, that pest to power and that stuff, some stuff on TikTok and all the other kind of outlets to get people informed. Anything and everything that can use.
Yeah. Thanks very much, Simeon. I mean, some of you will know that there was a fairly major Prostate Cancer UK awareness campaign just the other month, which featured both articles and local radio and TV, and quite a lot of coverage was given. Certainly in our own county, Hereford and Worcester, there were, I think, a series of days when interviews were done. I think Mary was on the local radio, and it did strike me at that time, and still does, we don't make enough time, we should do, to get ourselves onto the local radio from time to time, because this very morning they were yet again on Hereford and Worcester radio talking about cancer, screening, diagnosis and so on. And if I'd been ready and we had been ready, we could actually have pitched in to that sort of thing. So the whole lot, plan it and take it forward, okay? And I think it was the figure, about 14,000 men were not diagnosed compared with the previous period before the pandemic, Lisa, in this last period. Okay, anything at all further, Simeon, about what we should do here in deepest, darkest, rural, white, South Worcestershire? You've very kindly come tonight, but there are not very many coloured gentlemen in this audience here tonight, and to be frank, I haven't done very much to actually go and search for, getting in contact with and helping with the awareness in relation to certainly Afro-Caribbeans in this area. Do you think that we should be doing more things, and even how?
There's always a potential for doing more. This isn't being critical because I don't know what you're doing, but there's always a potential for doing more. And I mentioned I work with young people in my day job. And my starting point is you engage them in their comfort zones. So you go where they're at. So if I'm looking to work, if I'm doing some work targeted at young people who I know are involved in violence because they're selling drugs on the streets, I will go out on a Friday night, Saturday night, 3 o'clock in the morning on the corner where they're selling the drugs and talk to them there. That's where they're most comfortable. That's where they're at. You can't expect them to come to a room like this and sit down to talk with me. That's not feasible. So wherever people gather, you know, barbershops, football games, wherever it is, churches.
Yeah. Thanks, yeah. I mean, we need to make more effort in a variety of ways. Thank you, panel. Can we move on to the second area of testing, which is, the second area and the theme area, which is PSA testing. This has been a subject which has been a little fraught, shall I say, over the years, really. Quite clearly, there are advocates for having a national screening programme, and the science and what, of course, NICE and the recommendations are about show quite clearly that it's not that easy. So the questions that we had are quite interesting, of course. Are NICE and prostate management programme recommendations for PSA testing being followed adequately, said Paul, I think. And the UK relies on GPs to deliver PSA testing. Some GPs appear to be still refusing to use the PSA test as an indicator, said somebody. So there are screening issues here. Lisa, do you want to start us off anyway with what the current vogue and the current practice should be?
Well, I think that the problem with PSA, as you know, it's not the be-all and end-all. So the issue of screening loads and loads of men with a PSA, and the same happened with the Kidderminster, the group. Every man was going to have their PSA checked. You're going to pick up more cancer. We know that, and that's good. The problem is that you end up with a lot of men who go through a lot of tests, some of them quite invasive, like biopsies, and that's not without risk. And you find that they haven't got cancer. So you end up with a lot of false positives. And it's those men that are then disadvantaged, if you like. And I'm not saying going to clog up the system, but those are the men that end up taking up radiology time, biopsy time, consultant time, GP time. And that's why it's not a screening tool. It's not good enough, is the short answer.
Yeah, so clearly there are quite a few men in the audience tonight who were, in a sense, lucky enough to go to one of the events that have been held in the county in the past and were picked up, and rightly sing the praises of the fact that they were picked up and are still here to tell the tale. In the past, of course, through Mary's good help, lots of testing was done from Kidderminster, as I think Lisa referred to, and large numbers of people came forward. We haven't done so in this county now for quite a while, but other counties and certainly a lot of other support groups across the country are now returning to, not, of course, doing it themselves, but they get either the Graham Fulford Trust to do it and they assist with that process, or a combination of the hospitals elsewhere that may be interested in so doing. So the question is, I suppose, should we be looking to the private sector and using some of the funds that are raised to help do some of that? Or do you think, because of what you've just said, Lisa, we should not be doing it because, however small it might take, some resources from an already overburdened National Health Service?
I think, for me, there is risk factor. So, in my case, strong family history. I would recommend those people continue to ask, request, demand PSA tests. In Wolverhampton, our local trust is trialling a different way. They will not refer men to urology until there are 2 positive raised PSA tests, at least 28 days apart. and that kind of rules out UTIs. And so it's cutting down those false positives by about 80%. And that 28-day gap is something that doesn't cause any further harm to the man while he's waiting for the second PSA test.
Agreed, Chris?
Yeah,
Chris, you're-
absolutely.
you're,
I mean, I came across
nodding.
something earlier today which I thought was interesting. It was argued by a chap who's actually works in the labs that PSA has an accuracy of plus or minus 50%, roughly. So you could put the same sample through a machine 3 times and you might get 2.4, 2.8 or 3.1. So I think having two samples separated is really important. So instead of the lab saying, this is a result of 2.0, they should be saying we're 95% sure that it's somewhere between 1 and 3. So that gives you an idea of the vagaries of PSA and the fact that it can go up and down with time. So I would totally agree. I think the two separated out, that combination of the two tests improves the accuracy, reduces the false positives. I think we're still going to get them until we get a better test.
Can I just ask Chris, how, capacity-wise in GP land, is that going to be possible for you to keep an eye on?
When I was there 2.5
Reliably.
years ago, it would have been absolutely fine.
Yeah,
Yep.
but things have changed.
They have, yep.
I suppose
We'll come on to that. Yeah.
Yeah, I suppose, again, Simeon made mention really of targeting, didn't he, really? And it does, I mean, I'm certainly an advocate. My father died from prostate cancer. My brother was found to have it as well and had his whipped out in good time. I haven't got sons, but I would offer the same sort of advice to a son as well. So there's a targeting issue, is there not, as well? And the other thing, just to clarify from people up here, is actually the difference between PSA testing ahead of, screening as it were, and then once you're diagnosed anyway, and what some of us will go through and is done by the team up at Worcester as well when you've been diagnosed. So a big difference there.
Well, I personally, and I think I'm giving myself the same sort of treatment, if you like, the same screening as I would like to give patients, in that I've got a family history of prostate cancer, I'm over 50, and I'm therefore having a PSA every year. And if it's elevated, then it gets repeated. That's my rule of thumb.
Yeah. So Chris has a baseline, and it can be seen whether it's either spiking or whether it's moving or not. Okay.
I mean, guidelines at the end of the day are only guidelines, and they're there to be bent.
I also mentioned earlier, the GRAIL, the Gallery trials, which are underway at the moment. So in the trial phase, it's 140,000 people. Next year, it's going to be 500,000 the year after that, and then we'll see how things go in terms of the 51 cancers that we can identify. But that is likely to become a screening program. So it certainly will be, but there'll be 500,000 people a year screened for the first 2 years. But that's for all cancers. So it depends on which ones it's best at identifying at the earliest stage, on whether you'll be screened for that or you'll be screened for everything. There are some other things as well that are going on. There are targeted lung health checks, a screening program, particularly in areas where there was mining and heavy industry and so on. And I know that in Yorkshire, they're moving the cameras down and they're screening other bits of the body while they're examining people there as well. So look out for more of those kind of things happening as well, being screened for 3 or 4 things in one go.
Thanks, Simeon. Sorry, the lady who asked the question, do you want to add anything, or have we missed the point you were raising?
I've taken on board the answers that have been given, which make huge sense to me.
Can I make one point?
Please.
The private sector does not have anything better.
No.
They'll just do it more quickly. and it's as simple as that. And as we've talked about, waiting 28 days, that period of waiting can make a difference. So I would still suggest that that we stick with what the NHS has got.
Yeah. And the guidelines are quite clear. They are in this excellent book, without having to sell it, to do with targeting, age and family connection and so on, okay? So don't hesitate to pick up a copy of this subsequently, and I'm sure you'll be reassured by what is being advocated, not only by Lisa, but by the NHS.
But sorry, just one more thing. But with black men, it's 5 years younger, so it's 45 years old. They should start looking at having a regular PSA test, because they get it on average 5 years younger.
Right, thank you. Did you have a further point to add, Stephen?
It was just that those of us who've listened to Steve Allen talk about prostate cancer may remember him saying that the PSA is actually a very accurate test. It's what you do with it that's the problem.
Yeah.
And I think that's what's being highlighted tonight.
Yeah.
Yeah.
I think the point at which the test is requested, there has to be management of expectation, and I think that's a really crucial step that perhaps the modern general practice consulting is not helping. I think that's best done face to face.
Okay, well, that's a very good link, thank you, for our next theme, our third theme area, which...
Just before you go move on to the next.
Yes, okay.
We did that talk at Mazza. Is it Mazza?
Do you want to
When
just
did that
let me
talk?
pass this to you, because otherwise I'll be shouted at by Daniel.
When can you hear me? Sorry, like that. He's an expert on this. Yes, when we did the talk at the Mazza factory in Worcester, a lot of people came forward and told us that they weren't getting past the receptionists to get their PSA done. Even though they'd had it done in the past, they were being refused by people on a desk. So that's been a main concern over the last 2 years, that's been happening in lots and lots of practices.
I always find that a request to speak to the practice manager is incredibly powerful.
Absolutely.
So if you can get hold of one of them.
If- yeah.
My practice manager doesn't speak to members of the public.
No, well then you put it in writing, and you know it's
You don't get anything back. Anyway,
Well.
that's another story.
Put it in writing every week.
The issue of getting through to GPs and getting past receptionists is a very difficult one, and it's something that I've raised recently at a national level. Mentioned my eldest brother, his son who lives in London, who's 41, started having symptoms. I suggested he go for a PSA test. Finally managed to persuade him. He went to his GP, and he was told by a nurse, "You're too young. We think it's inappropriate." That was over the telephone. They don't know anything about family history. They didn't know his ethnicity. All they heard was a voice. So that face-to-face thing is so important, and people being persistent.
They're frightened too half the time, because they've very often been waiting on a phone call for ages
Yeah.
anyway. They're 13 with you, and then they get these blockages, and then they think they're being a nuisance. People don't want to be a nuisance to their surgeries, and that's the problem.
Well, I sent him to A&E, and he was diagnosed with prostate cancer in A&E, and that's disgraceful that that should happen today. Persistence.
If there is a link like that, it should be from 40, in my opinion.
I think you've all, of course, touched rightly on the fact that taking responsibility for our own health and actually seeking both to know about it, knowledge empowers again, and understanding what the ground rules are for both dealing with it by getting hold of your GP or somebody else, or learning more about it, is crucial. But you can imagine that quite a swathe of the questions that we received did touch on this communication issue of getting to the right person at the right time and getting the right answers. So the heading we had was taking responsibility, providing information and support. But this is a general theme, really, about failure, really, in lots of cases, to either get the right diagnosis, as we just heard, or the right treatment. Anyway, questions we've had from friends and colleagues here that we had were, at which stage of a man's journey should information be provided? GP surgeries, diagnosis stage, treatment stage, urology or oncology, or CNS nurses? GPs used to start diagnosis, a certain doctor said, face-to-face. Does this not count anymore? I have a nasty feeling this has to do with resources and all sorts of reasons, and it's unfair to ask you, Chris, but we'll anyway. So, can you...
It's quite easy for me because I don't work in general practice anymore. But I do speak to GPs, and there's quite a lot of anger in the profession at the perception that they are not seeing people face to face. So, to stand up for them, that is their sort of perception of things. I think conversations like this and on so many subjects have to be face to face. You can't do a rectal examination on Zoom. You've got to see somebody.
Chris Packham tried last night, didn't he, on Springwatch?
You've got to have an immediacy and be aware of their non-verbal communication as well as what's being said on the phone simply. So I think it's really important that we do see people, as GPs do see people face to face. And I think it comes back to that point we made earlier on. There is an insistence you have to get past the receptionist who's had no medical training. And I think if you're armed with information from here or from another source, then you can get through. But it's important to be reasonable. If you're seen as being too assertive, that can put up their backs, and then you meet a brick wall. So you've got to be the right type of assertive, but without being aggressive. And I think if you're not getting anywhere, then you take it one step higher. And a written letter of complaint is always it always tends to cause shockwaves, I must say.
Yeah, I mean, I read a short piece today in the Times, a regular Tuesday piece by the Times doctor, who indicated that 45% of patients are still being seen face-to-face, actually, just to put a stat out in front of you. But just so that we haven't missed the right point, the question I started with is actually from Dr. Dick Herbert. Would you like to add to what has been said or detract from what I've said already, Dick?
I've been retired from general practice for nearly 20 years.
I think I better bring this to you.
I've been retired from general practice for nearly 20 years. It was a busy practice of 11,000 plus. About 2 weeks ago, I had to take my wife to see GP just to obtain a letter. This was a Monday afternoon. They share a building with another practice of 11,000 patients. There was not one patient in the waiting room on a Monday afternoon. Mm-hmm. That I find incredible, and frankly, I'm quite ashamed of what's going on. As Dr. Perks says, you cannot diagnose things over a video. A simple example: child preschool comes with earache. Is it nasal congestion or acute infection of the ear? You can't put an oroscope down a Zoom. So I don't care what they're saying. I don't believe them. I'm sorry.
Thanks, Dick.
Can I just...
Do you want to add? Sorry.
I was just going to answer the question about where information needs to come from. I think, to be honest, it's got to be at every stage.
Yeah.
So I think it starts at the point you have a PSA test and you have your digital rectal examination by your GP. It should be given then. And as you go through the process, each member that you see should be giving you information, whether that's written or verbal, or whether it's a link to a website or something. It needs to be all the way through, I think.
I'd probably wait until after the rectal exam.
Possibly.
We mustn't beat ourselves up and the medical profession up too much, but it bears repeating just how many examples we can come across. A colleague in the room actually made mention of his example. At a hospital diagnosis, I was provided with no opportunity to speak to anyone, just provided with a pile of pamphlets and not made aware of facilities or services. Does this seem right to the panel? And how should specialist services, anyway, be made known to us? That's quite a lengthy one, but anyway, first part.
So the first answer is yes, he should have been given information whenever that was or wherever that was. I think I know who the patient is, but I don't know which part of his pathway he's talking about. And I didn't quite understand the last part of his question, to be honest.
Yeah, I think the question really referred to provision of advanced prostate cancer treatment requiring further oncology specialist services. And I think we perhaps shouldn't venture too much into personal examples really
No.
beyond what's been said. But it was just that it raised for me the profound difficulty of all of us as patients. If you don't know that something there, how do you know to ask for it? You know, it's that fundamental issue, isn't it, really?
I mean, that,
Knowledge empowers. I'm making a big deal of this tonight, not to do with that particular publication, but to do with the fact that if you don't know the questions to ask, you cannot possibly follow it up and ask for help, whether it's through the CNS nurse, whether it's through laser and oncology, whether it's your GP, doctor or whatever. I regret to say, you know, that whilst we'd love to move back 20, 30 years, to be able to have face-to-face discussions with somebody who really put our case, our circumstance, knowledge of our family into context and put you in the right direction, point you in the right direction. These days, I'm afraid, it strikes me we have to do a bit more homework and be ready ourselves to push the boat out. Am I right or wrong, I suppose?
we did, a group of us patient reps did a piece of research on behalf of the NHS about patients who failed to show up at hospital for their first, they're put on a 14-day fast track, 14-day wait, and they failed to appear for that first appointment. And when we followed up and spoke to those patients, it was over 90% of them didn't know that it was anything to do with cancer that they were being referred for. So if they're not told, and they may have a holiday booked to go somewhere at the same time, they don't want to lose their holiday, they go on their holiday and try to rebook afterwards. So there's a failure there of communication at that stage. We've also did another focus group with men that weren't accessing radical treatment, so radiotherapy or surgery. And one of them talked about being given a load of information, a folder of information, and being told by the urologist that he was about to go away on holiday, he was seeing another patient, and he'd got 15 minutes to make a decision about what option he wanted to take. And that was his option, so he decided not to go with surgery, and then regretted it kind of later on. So there are all kinds of failures at all kinds of stages of people not being told information. When you go and you see your consultant and there's a discussion with you, that consultant is meant to send a copy to your GP, but send you a copy as well. How many times has that failed to happen? Your consultant says you need to have this particular bit of medication, but your GP that's going to prescribe it. And 10 days later, I go to my GP and the GP knows nothing about it because the hospital hasn't written and told them. There are all kinds of breakdowns in communication that affect us in all kinds of ways. And it's for us to know and to take some responsibility where we can to say, you should have received this, or are you going to give me a copy of that the decision that we talked about at this consultation.
Go on.
Yeah, I was just going to say this probably brings us up into the next part of the conversation about capacity. Unfortunately, I as a consultant, I have 15 minutes per patient, and I think in GP it's 7 minutes or something. I have half an hour to see a new patient, so that's not very long to see someone, talk about the diagnosis, talk about treatments. It just isn't enough time, but unfortunately that's what we're working with.
I don't think we're talking about a lack of empathy or a lack
No,
of care.
no.
What we're talking about is a lack of time for those things.
Yeah.
And that's due to the NHS being run down, and we keep voting for a government that does that. So,
Yeah.
political point, but keep voting the same way, you'll get the
Yeah.
same thing.
I think unfortunately it's just the reality of actually what it's like on the ground. None of us like it.
But that's where the role of the CNSs come in terms of support. And being on the board of West Midlands Cancer Alliance, I know that we've recently approved funding for, I forget how many additional CNSs to be trained. The problem is recruiting them onto that. The opportunities being put out there. Similarly with people to do radiotherapy. The training and bursaries are being made available, but can't get people to take those roles up.
And there's another issue with CNS recruitment in that the trust won't pay for them. And that's basically the problem.
And again,
I-
from the Cancer Alliance.
The trust still have to pay part of the fee. So I have one CNS for my metastatic workload, and actually she treats the whole of the West Midlands. It is just one person.
Sorry.
A clinical nurse specialist. So CNSs generally work alongside doctors, and they're much more holistic than we are, because they are supposed to have more time to talk about all the extra things that are important to folks. But there is one metastatic prostate CNS for the whole of the West Midlands. Sorry, the whole of Worcestershire, not the West Midlands.
Worcestershire,
God.
yeah.
Yeah.
And she's brilliant, but
She is brilliant,
she
but
can't
she's
work.
only one person.
I think there's only a couple of things that one can say in positive response in a way. One is the one I'm afraid I've made, that we have to take responsibility and challenge. So if you've been promised that you will get something back in 3 weeks' time, you follow it up in 3 weeks' time if you haven't heard. It sounds very basic, but in the medical world, it's essential that you follow it up. Okay, so there's a responsibility in all sorts of different ways for ourselves. But there's a follow-up sort of question which we had from somebody here, which was about really how volunteer groups and support groups like ourselves really can or cannot help in a variety of ways. Clearly we do little bits and pieces, but there are, for example, patient panels, Chris, to do with GP surgeries, etc. For example, should the support group be getting more involved and expect to be part of patient panels anyway, to get our voice heard anyway? Is that something that's worth doing? You look dubious. I'll give you time.
I mean, maybe I can say within certainly cancer services, there are things called EAGs, which is an expert advisory group. There is always a patient representative on those groups. There are a number of other groups like radiotherapy action groups, chemotherapy groups. All of them generally have a patient representative on there, if not two. So it does exist.
I mean, we have flirted with the idea, let me put it no stronger than that, that we as a support group should offer to, say, Macmillan to go along from time to time, say when the urology clinics are held, and make a number of us available on a rota basis for a couple of hours apiece or something, to help the Macmillan people when there are those urology clinics, to be available to do just what we do anyway, buddying chats with people, point people in the right direction, no more than that. But do you think there's a place for that sort of thing at all, Lisa and Cindy?
You go.
Absolutely. But there needs to be a distinction between support and where I've seen people trying to give clinical guidance. And you know, that's the only thing for me to guard against. It's a support group. It's about, you know, talking to men, their partners, wives, etc., that are going through this, and just kind of bringing a bit of that kind of experience to it. You know, yeah, it really is important. It's. I got my support at the time because my local support group, quite frankly, when I walked in, I compared it to Dad's Army. The chairman was Captain Mannering, you know, and then the vice chair was Wilson, and then you had Jones who ran around making the coffee, you know, and they ran it like a little fiefdom, and everybody else was kind of on their territory, and you didn't feel welcomed. And I went to one meeting, and I thought I'll go back and give it another try, and I walked out halfway through that one. So not all support groups really offer support. Some are much better than others. So I used Prostate Cancer UK and their nurses. And when I was at an absolute low, you know, Windrush scandal was mentioned. I was being threatened with deportation. I've been here since I was 5. That's a whole other story. I had prostate cancer. My partner had breast cancer. Couldn't pay our bills and all the rest of it because I couldn't work either. I was at a stage where I just wanted to end it all. And it was Prostate Cancer UK and their nurses and hours of speaking to them on the phone that provided that emotional support, but also information. One of the things that I got from Macmillan was the fact that they had a scheme with NPower that if you're diagnosed with cancer, they will negotiate a dual fuel fixed tariff for cancer patients. That brought our dual fuel down to £40 a month, which was something that kept us kind of going during that period. So some of us are trying to get that, incidentally, at the moment, to have that rolled out nationally, trying to get government involved in supporting that, and all the big energy companies. Given the crisis that we're in at the moment, come the winter, some people with cancer are going to really feel it. So, you know, support groups can do all kinds of things like lobby and so on. Sorry, I'll rant on all day, but...
No, that's very helpful. That's very helpful. I mean, I think if you listen to Mary at any meeting or at events that she looks after, you will hear her say really the same about the buddy role, that we're not here to give advice and guidance. We're to try and listen and to share the right sort of direction that people need to go in, and to be a listening ear and share what you've gone through yourself or who might be able to help. We do think that's, as Simeon says, is something that could be expanded more. I know Mary gets still quite a lot of calls. I get a number from people who are quite distressed, and really they need somebody just to talk to and be pointed in the right direction, and there's a lot of that still to be done.
I think that reflects the fact that when you're given some bad news, whether it's in Lisa's clinic or in a GP surgery or wherever, you stop listening when people talk about cancer, because that's sinking in. Yep. You stop listening to all of the other discussions, and the questions that come up then will come up at 3 or 4 in the morning when you're getting up at night. They'll come up when you're having breakfast. They will come up at other times, and that's where groups like this can be so helpful. And certainly when I was practicing, I would see an awful lot of people who would come and see me and say, I don't really understand what's gone on, even if they had got the letter. The letter's full of jargon, they don't understand it, they don't know what it means. And I think all of those support, from general practice, the CNS, to support groups like this, all of us need to be available to answer those questions as they come up.
Yeah. Availability at the right time is fairly crucial. But as I think I stress, Mary's very keen. Anybody involved in our support group has been to the buddying course, and in fact there's a number of these going on with other support groups across the West Midland region at the moment. Tackle, that has been mentioned, has a really, really good regional representative, a chap called Aidan Adkins from the Solihull Group, who is a trustee of Tackle now, who is actually coming to our coffee and chat at Droitwich, isn't he, before long. But he has been running a 2-day buddying course for their own group up in Birmingham at this time, in fact. Okay, I think we should just hold 1 second. It's 8:10. And have a tiny break before this last session about going forward. Lots of exciting, innovative and research and development stuff, I'm sure, to talk about. Let's just take a break 1 second on a different tack. Bear with me, because I know that on the back row there we have Councillor Chris Parsons, and I want to again pay tribute to the terrific work that he did during his mayoral tenure of 2 years, raising quite a sizable fund of money, which actually is now sitting in a bank. And Chris tells me tonight that he's actually got a checkbook. So we are now sort of launched, and we're actually on the lookout for good projects that could be supported in the Pershore area, helping men or families affected by prostate cancer in any way, shape or form. If you know somebody in difficulty, or you can think of certain things that should be supported to do with prostate cancer in this area, for goodness sake, get in touch with us. Do you want to add anything to that, Chris? Thank you for coming.
Thanks, Gordon. You have to excuse my speech. I'm actually full up with hay fever, but this time of year, who isn't? As Gordon said, I've been a member of Pershore Town Council for some 35 years, and I've been privileged for 11 of those years I served as town mayor. And it's tradition that when you're mayor of the town, you adopt a charity and raise funds. And over those 11 years, we've raised over £50,000 for various cancer charities. In the last time that I was mayor, I set up a Pershore Prostate Cancer Support Fund. And during that time, with Gordon's help and with the help of many of the Pershore residents, we raised £12,500. That £12,500 is finally sitting in a bank account, and it took almost 12 months with Lloyds Bank to get the account open, but that's another story. They obviously have made a note of every phone call I made to them, because they now send me a new checkbook and a new paying-in book pretty well every week. So most of those are ending up in the bin because we only need one. So there's £12,500, and the charity, the fund, is called Pershore Prostate Cancer Support Fund. And it's there to support many different aspects of people who need help financially. We've got 3 trustees to the fund. Gordon is one of the trustees. Someone else who you may know is Jo Dodd. She was a nurse, and she's actively involved, I think, in the Wellbeing Hub, isn't she? Lovely lass. And the 3rd trustee is myself. So if you need access financially and help in any way, please contact primarily Gordon, but any of us will do, and we'll see what we can do to help you out. The reason we've set it up as a separate trust, £12,500 won't last forever. So with it being set up in that way, if the money starts to dwindle, we may organise some fundraising events to top the fund up, to keep it going. And it's there for you guys to benefit from. Thank you very much.
Thanks very much, Chris. Oh, Councillor. Yes, Councillor. Slightly worrying, isn't it, that Lloyds Bank needs to do all that checking about money laundering from somebody who was chair of the town council, really.
Perhaps they know him.
There is something worrying about that, isn't there? Anyway, thanks a lot. A huge amount of effort, and a lot of people in this town contributed over some time, so let's make good use of it. Let's go forward then, really. As I said a few moments ago, there have been tremendous advances in the way that this disease is dealt with. I shared with Chris the fact, when I was first talked to by a consultant in Leeds all those years ago, 20 plus years ago, was it? I certainly didn't get any literature, certainly didn't get any information, certainly didn't see a CNS, certainly not Ronnie. It was, on your bike, get home, and we'll be in touch with you later. Apart from the fact that the system of treatment, of course, was very, very different. So let's move forward. A question that we had, which I thought really was quite interesting for going forward, really, as a general, really. Radical open surgery prostatectomy was quite common for many of our members. What treatment would they expect now? That's from Ian. What new advances in treatment do you envisage for advanced prostate cancer patients in the future? How soon will SABRE treatment be available in Worcestershire?
Gosh.
It
Where
sounds
do you want me
like
to start?
Might be yours, Lisa, yes. Is that okay?
So I'm sure you're all aware that Rory the robot is coming. I don't know when he's actually going to be in place in Redditch. So the robotic machine will be coming to Worcestershire. They've just employed, so Urology have just employed another urological surgeon who is a robotic surgeon. So he'll be heading up that service, hopefully. So I guess that's one answer, is that hopefully men will be receiving robotic surgery as well as open surgery. There are some men who still need open surgery. I don't want to speak for Mr. McCarr, but you all know. So that's one thing. Radiotherapy has always been available. I think now we try and push it a little bit more than perhaps it was maybe 10, 15 years ago. And that might be because we've now got Worcester open. So it's a bit easier for men to get to treatment. There's also a lot more representation from oncology at MDTs. So there's myself and there's 2 other oncologists that treat prostate cancer in Worcestershire. And we all go to the MDT and we're all fairly, what's the right word? Assertive. So we get our point across. So certainly my numbers have gone up over the last few years. More patients are coming my way for radiotherapy. What was the other question? About SABRE.
SABRE.
Okay.
How soon will it be?
So SABRE is now, we have been approved to do SABRE for other indications. So that means for men who, or any cancer patient actually who's got metastases. So we're allowed to do SABRE for bony metastases or lymph node metastases. So we can do that locally in Worcester now. I'm going through a process of getting accredited to do spinal SABRE. So that's particularly for blobs in the spine. For radiotherapy, we've just completed recruitment to the PACE-C trial, which I think we talked about in Kidderminster recently. So this was a trial of standard radiotherapy, which, as you know, is the 4 weeks of radiotherapy now versus essentially 1.5 weeks of radiotherapy. That trial is now closed, so we can't recruit any more into that. But there is another follow-up PACE study, which is coming, and we're probably going to be opening that within the next 6 months or so. So at the moment, prostate SABRE treatment is only available within trials. It is not yet available as standard treatment. My hope over the next 5 years, which comes back to your other question, is that it will become standard for all men with prostate cancer. I'm sure certainly the people I've seen who've gone through SABRE within the trial, they're all fine. They don't have any significant problems other than what you'd expect. And they've all really enjoyed just having 5 days of treatment rather than 20. Makes sense.
Yeah, thanks, Lisa. I don't know what it means either. SABRE, for those, I can read it out.
Stereotactic ablative body radiotherapy.
That's why we use the word SABRE, okay?
Yeah.
Okay.
It just means giving a higher dose of radiotherapy per dose of radiotherapy. So you don't need to give as many doses. You can give a bigger dose each time that you give treatment.
And there are always advances, and we hear advances in the robotic surgery field as well, but are there more pieces, are there further equipment needs in relation to oncology at the moment, other than this direction you've just mentioned of Sabre?
Not Sabre at the moment. We've got all the equipment we need. So it's just going through a process of accreditation, which is government driven, so it's nationally driven. What we'd really like to do in the future is to have an MRI scanner within our department so that we can use an MRI fused with the... Do you remember when you all went for a CT scan to have your radiotherapy marked up? The plan would be to get an MRI scan of you and marry that up to the CT scan so that we've got both to plan on. That makes things a little bit easier for us and more accurate. That will cost a lot of money.
Well, no problem in Worcestershire. There were, of course, two important pieces of kit, I understand, those compression abdominal pieces of kit that I don't know how many people in the audience actually know, but thanks to Paul sorting it out as well, we made a quite biggish contribution to the Worcester Trust alongside the Friends of Pershore Hospital, actually, to make sure those pieces of kit were installed as fast as possible. So thank you to anyone who contributed through their subs or events to that process.
Yes, thank you as well. We've got them installed.
Good.
Thank you.
Good. Thanks. Semin.
I'm guessing you got the clearance to actually have the robot on site because there was a group of patients at a hospital in a region who raised the money, but it wasn't cleared by the NHS for them to have a robot, and indeed there was nobody to use it. And so the money sat in a bank account for about 3 years that I know of.
I'm afraid that sounds remarkably similar to Worcestershire, and so similar that it could even be Worcestershire.
It's probably the same.
Sorry.
Yeah.
And it's now, as I say, it's now just short of 500,000 that's sitting there in that bank account, ready to be used for deposits and running and one thing and another. Okay.
So what's really interesting, though, a slight aside, was that I was at just before the pandemic, I was at the NHS Confederation conference, which was in Manchester, and they had one of these robots for people to trial.
Right.
And I could do your surgery. I was able to peel a grape. Absolutely fantastic.
Is the answer to
So
that?
if you want somebody, I volunteer.
Is the answer to that? Oh, good or not? I think perhaps we move to another point that regrettably somebody couldn't be with us tonight, but asked a really interesting and slightly longer question than I shall bowl at our panel tonight. I don't know whether some of you remember, but we had a chap who came from the south who had received proton beam treatment down in South Wales. Timon Colgrave, who comes from the south. And I don't know how many of you have read in the newspapers, but regrettably, the Rutherford Health Group, which was behind a number of these proton beam centres, has gone into liquidation anyway. And there may be some delay now in the ability of men to get that treatment, even if they can afford it and want it. But my friend Peter over there is scurrying to try and find the precise question, but it reads along the lines of, are we likely to see proton beam treatment in the near future in Worcestershire? And you'll understand why I've asked that question following my explanation. But
Well, the easy
Lisa?
answer is no.
yeah.
Completely no.
And from a purely technical point of view, though, I mean, as a layperson, I've read the bits and pieces. It looks as though for some patients it could actually be quite a lot better treatment than others, but not.
There isn't a huge amount of evidence still for prostate cancer,
Right.
for proton therapy over and above Sabre, for example. Proton therapy, yes, it's very convenient. Technically, it's not really much different than standard radiotherapy. So for people like me, it's not really any different.
Right.
It is meant to reduce your toxicity, particularly rectal toxicity, but again, with the advances of Sabre and sometimes rectal spacers,
Yeah.
it may well not ever be clinically relevant, to be honest.
Hugely expensive. Of course, that's a part of the answer, I'm afraid, isn't it? Okay, have I missed anything, Peter, in relation to what Tim had kindly sent on to us? Because we were both pleased.
Some of you may be able to remember that exactly a year ago in the Svoboda magazine we had a photograph of Timon, and he told us about the proton beam therapy, and I think it was a little bit of a shock, to me when he came back a few days ago, to say that really that it looks as if things are not going anywhere in the UK with the closing down of 4 of the Rutherford centres. The one thing that he mentioned, and I don't know if Lisa or anybody, maybe Celia knows a bit about this. I think he said that the Facebook that the prostate cancer support groups that proton beam therapy had been kind of banned as a
Yeah, I think he was. Sorry, I know that you can't be heard by everybody, and because the camera's facing the other way, I'll just say that his concern in large measure was due to the fact that there was almost a banning of interchange of views and social media comment, apparently. Now, whether that was because of the financial side, I don't know. And I think, correct what I said earlier, I think it's only the 2 places that actually were Rutherford Health. 2 were actually up at Christie's at Manchester, weren't they? Well, sorry, one at Christie's and 1 down in London, weren't they, Lisa? So I was wrong, sorry, in saying they were all Rutherford. 2 were Rutherford.
Well, isn't it Wales?
Yeah, Wales, yeah.
Yeah.
Anyway, it's looking rather unfortunate, to say the very least of it. One likes to see new technology being tested fully and being shown to either work or not. And I'm not sure whether we'd really got to that point. Anyway, okay. Can I follow up with another technical question, really, which is we have a number of members, certainly 1 or 2 present, but a number not, who've actually mentioned the fact that they are dealing with lymphedema. And it's quite clear that some people have had real difficulty getting specialist help and care. Sorry to come back to you again, Lisa, but do you know what the position is about lymphedema services in the county at the moment?
Yeah, I mean, in general, lymphedema occurs when you've had surgery and a lymphadenectomy. Very rarely is it caused by radiotherapy alone. So to be honest, the only patients that I see with lymphedema are those that have gone through surgery and come to me for other reasons. The only group that I'm aware of is the Pershore group locally. They are completely overwhelmed, I think. Chris can probably say more about it.
Yeah, I don't know an awful lot about it other than
I think they've been down on staff. I think there's only one lady that's even running it.
Yeah, I think
it's very difficult.
What I was going to say, I think, is that the issue of lymphedema caused by surgery it brought into my mind the idea that all of these advances in treatment are about improving accuracy. You can peel a grape and so forth. If we're trying to remove tumour cells, there is a fine line, but nobody can hit the fine line. So you often take not enough, in which case you leave some cancer behind, or you take too much and you cause damage to surrounding tissue. And all of these advances will improve accuracy, but they're still not, I don't think, going to get down to accurately removing all of the cancers. And I think we've got to look at novel therapies such as immunotherapy and so forth, for instance, which is really making huge strides. I think that's going to work, has the potential to work on a cellular level. I know it's been used and still being researched in melanoma treatment and has made a huge difference there. Is there anything on the cards in terms of prostate cancer?
So immunotherapy now is probably used in pretty much every cancer apart from prostate cancer. I use, with my melanoma work, I use immunotherapy, renal cancers, bladder cancers. Pretty much everything has got immunotherapy. it sounds very nice and fancy. Immunotherapy has very unpredictable, potentially very serious side effects. So it's not the be all and end all, definitely. And the longer we're using immunotherapy, the more problems we're discovering, even after patients have finished treatment. So it can have very long lasting, very difficult side effects to deal with. Immunotherapy within prostate cancer is still within clinical trials, and I don't think there's any men here, but there are a number of patients that I've sent down to London, and a few of them have had immunotherapy or are having immunotherapy and are doing very well. So my hope within the next 5 years is that it will become part of our standard treatment. So at the moment we've just got hormones and chemotherapy essentially. So yeah, hopefully it'll come.
And brachytherapy, where does that fit in?
Brachytherapy is for essentially for radical treatment. So brachytherapy is a form of radiotherapy. So it wouldn't come in the metastatic setting. Brachytherapy, in my opinion, is probably going out of fashion because of Sabre. I used to do brachytherapy in Cheltenham, and when the urology team in Cheltenham got the robot, all of our brachytherapy patients just went for surgery. So something always trumps. Yeah, I think it probably will go out of fashion.
Yeah. And so that wasn't very long ago, and yet again, it's an example of the way that technology and improvements in medical advances are helping enormously, really. Thank you very much. I think we should try and, well, we should not try, we will wind up. I'm in danger of asking the usual wrong question at a time like this, and asking the floor whether I've missed anything that you have had a burning desire to point out that we've actually not asked, that was really you were going to expect to be dealt with tonight. I'm conscious that I have said that I'd try and finish at 8:30, so we've got minus 3 minutes. So I saw one figure there, and I've seen Mary over there. So we'll take those two, and then we will have to end, I'm afraid.
There was another gentleman here.
Yeah. Oh, I never miss Harvey, don't we? Yes, sorry.
Well, I was 20 minutes late, so.
Okay, gentleman sitting down over there. Would you like to ask your question, sir?
What I was going to say, you mentioned brachytherapy. Well, I had that in 2006. I was operated by Dr. Owen at Cheltenham.
Yeah.
And I've had no problems whatsoever.
Yeah.
It was absolutely brilliant.
Yeah.
Good.
Thank you.
Yeah, it's good.
Thank you very much. It's good, isn't it, to hear that all these now old-fashioned systems actually worked. Was there somebody over here wanted to? Just waving at me again. Right, okay. Okay. Well, in that case, I shall come back to Harvey on the front line here. Mr. Vivian, you had a question, I believe.
I did. Nobody's mentioned late effects.
Yeah, sure, yes. I've
all of the conversation.
I've had prostate cancer. I've had the treatment, excellent treatment, radiotherapy, and the PSA is now down to 0.1, perhaps 0.2. But there we are. So, but I do like to have I do have private medical insurance, and I thought of changing, save a few pounds. But there was an exclusion clause put in which said if prostate cancer goes to other parts of the body, and in fact, actually, I want to have the exact wording. Can you just hold it first? Get it? So it was rather important. There we go. It says the exclusion was prostate cancer, including any spread of this cancer to other parts of the body. So the question is, well, I stayed with my existing insurer, but the question is prostate cancer likely to go to other parts of the body, and will I make Christmas?
I can tell you he'll make Christmas, by the way, but you know.
As long as you're not a turkey, I don't see why not.
Of course, prostate cancer can spread to other parts of the body, and that's why treatment fails. But that's also why you get followed up.
Sorry?
That's also why you get followed up.
Oh, okay.
Yeah.
But of course, unfortunately, insurers use every device in the book, every clause they can, to make sure that poor old Mr. Vivian can't claim on his insurance. So you can bet your bottom dollar. Okay, one last, very quick one. We'll only take just a quick response from each of our three panellists. Had a lovely, lovely general question, which is so difficult that they will love this one. You have both a crystal ball and a magic wand. What one thing would you wish to see happen in the management and diagnosis of prostate cancer in the next 5 years? I haven't a clue what I would answer, so thank goodness I can pass it to you. Anybody got any good answers there?
Effective treatment without any side effects. That's what I'd like.
Thank you. Look, I'd go for that as well. Right, good.
So would I, but I suppose that we fund the treatment on same levels as other countries on the continent even.
Right.
You know, our funding is despicable in this country for cancer compared to elsewhere. And that's why we have some of the poorest outcomes in Europe.
Yeah, thanks, Simon.
I was going to say more accurate screening that can be done in primary
screening-
care.
A screening test that actually would work cheaply? Three good answers, aren't they? That's terrific. I will thank them properly in one moment, but just a couple more things to try and wrap up as we come towards the end of this evening. Thank you for staying with us. Not many people left apart from those gentlemen needing to go to the little boy's room. The South Worcestershire Prostate Cancer Group has got one or two events coming up this year. I'm delighted to say that we shall have a presence at the Plum Festival on the 29th of August. That is a terrific event that some of you have helped me with in the past, and we've had loads and loads of people coming up asking questions and wanting information and partaking of the tombola even. But anyway, that's the 29th of August. Please, 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 if you haven't already signed up, as I'm sure Kay tried to get you to sign up on the way in tonight, and you think you might be available on that bank holiday Monday, just for a couple of hours, I'll do a rota as before. Please, please let me know, and let's make a big deal of it. Spreading awareness and flying the flag for prostate cancer. So that's the first thing. Secondly, to remind you, the Mayor's Prostate Cancer Fund. Ideas for who might be helped by it or suggestions of how we should use it really would be very welcome. We'd love to hear from you. And then we've got a number of meetings coming up which are slightly less formal than tonight. Peter Corbishley over there has helped me enormously with, in fact was the instigator of one or two coffee and cakes, as we've called them really. And fairly shortly, on July the 15th, I think it is, at the, and I'll pronounce it wrongly, I'm sure, the Gaudo Lucy Golf Club. Yeah? Gaudo, you know. Okay. The Golf Club in Droitwich, right? There's going to be a coffee and cake from 10:30 to 12 o'clock, and we'll give some publicity to that. Those who have received their supporter magazine already, look on the back page. For the events, you'll find the details there. Kidderminster has got its summer meeting, Mary, on July the 19th, a date that's very finely impressed on her diary, I know. So that is correct, isn't it, Mary? July the 19th, the next Kidderminster meeting, when a certain Dr. Steve Allen, who is now chairman of Tackle, as been said, is going to talk up there. We've actually got Dr. Steve Allen coming to our own October meeting on October the 12th here in Pershore as well. Before I forget again, as usual, we've got a raffle, haven't we? Bear with us just for one moment. And the three celebrity panel members will dive in and give us the winning tickets. Where's Stephen? You'll have to be very fast. Anybody got any money that they want to put into a ticket? Otherwise, we'll start calling the... Right. Okay, shall I get somebody to take the first one? Chris, would you like to take one out of there? Thank you very much. And the number is 277. 277. Right, would you like to select yourself? a prize, that would be terrific. And before you move off, would you like to choose another one? Thank you very much. We'll let that one go, and we'll just have the one that's in your hand. It's called random. It's called random. The next number is 242. These are all blue. Do help yourself. After this lady's picked her choice, I saw you running. Okay. Would you like to pick a number? One out of there?
I missed the clinical contact and continuity problem solving. I don't miss the and working with some of the people I was working with and so forth. You know.
And the next one is 251. 251. Anybody found a 251? Fairly quickly, otherwise I shall get another number out. 251. 251. Right, last chance. And another number now is 235. 235? Good on you. Well done, John. And the next one. The next one is 275. 275? Have you got a second one? Better go and help yourself then. How many more prizes have we got, Stephen? Where's Stephen? I thought he was... Okay, 270. Off you go. Very good. Making this as fast as I can. And the final one, I think, now is 243. Off you go. Thank you very much. Is that the last one? Ooh. Okay. Thank you ever so much for bearing with me. Okay. Right. Let us wrap up. I think all that remains to me to do really is to thank very sincerely these three eminent panel members for sparing us the time to come and chat and talk about some very, very difficult questions. It does help us enormously to think about the world we live in and our prostate issues. And I'm delighted to say that, you know, we've got, 40-odd people here today, and we're all going to go home and take charge of asking the right questions to the right people at the right time. We're all going to vote and vote to come on August Bank Holiday and help with the Plum Festival rota. And we are delighted to offer our panel a bottle of very, very cheap wine.
Splendid. Splendid.
Because the Treasurer hasn't yet approved this.
I'm trying to give it away.
If you don't want it, just leave it on the table and we'll clear up at the end. Can I thank you all for coming, as ever. Let us know if you want different formats. I think I'd love to do this again. Well, I'd love to get a chairman to do it again. But I think helping us to understand the way that the world of prostate is moving and getting questions from you is a really key part of this operation. So thank you very much. Travel home safely, and please show your appreciation to the panel in the usual way. Thank you. Hope to see you again.